invitation, and thanks the AIOC organizing committee for this opportunity. So moving on, I will be speaking on retinoblastoma, what is new. So we know that the burden of retinoblastoma there in worldwide is around 5,000 new cases per year, which is approximately 30% which we in our country are handling it. With the improvement of this various treatment modalities, the survival rate in developed countries has now shown to be more than 90%. The clinical profile which we see here in Indian study and Indian Western literature, we see that local advanced and metastatic diseases are more in case of the Indian population. There's around 40%, whereas compared to 10% in case of Western population. The reason behind is because of poverty, illiteracy, lack of awareness, lack of adequate screening, delay in the referral, and lack of access to health facility and alternate system of medicine. Coming to the clinical presentation, the most clinical common presentation is leukocoria, which comprises of around 50 to 60% of the cases. Then you have got the squint, you have got this red eye, you have got this hyphema. Sometimes you can get this buphthamos with hapstri and secondary glaucoma. Sometimes you can masquerade with uveitis, and so you get pseudohypopen out here. Sometimes it present as thysis bulbi. Now sometimes it can present as orbital cellulitis, and you can get a very large proptosis, and secondary orbital retinoblastoma can be occurred, which may be associated with the lymph node metastasis. So with this varieties of presentation, what to do next? So in order to diagnosis, the main fundamental is like indirect ophthalmoscope, which has been supported by the ultrasound and the MRI and sometimes CT scan. So you have to do examination under anesthesia to classify the extent of the disease and to guide the treatment. So these are the things which are required in doing this in the aura while doing EV. Ultrasound is if you see the irregular heterogeneous mass lesion arising from retina going toward the vitreous with interlesional calcification, which is seen with high spike, which is very classical for diagnosing retinoblastoma. MRI usually asks requests for this contrast enhanced and fat suppressed in all axial, coronal, and sagittal section. And in Q2 weighted image, you see the hypointense lesion, and T1 weighted image, you can see hyper-reflective images, and you see in this lesion, you see the leptomeningeal spread is there. So it's very useful for the local spread and for looking for metastasis. CT scan sometimes is useful when it's difficult to look for the calcification, especially when it's associated with vitreous hemorrhage along with the mass. So sometimes it may be useful to look for the calcification. However, not commonly used nowadays. Coming to RedChem is a wide field immune system, very important instrument. Give a 130-degree view of the retinal fundus screening, and also it help in the follow-up of the patients, and also to change any further treatment or any other further management need to be done. That is give us serial photographs. Coming to the retinoblastoma growth pattern, you see you have the endophytic retinoblastoma, that is tumor growing toward the vitreous. You see the exophytic retinoblastoma with mass, and overlying the mass you see the vessels. You can see most common is mixed type, and sometimes you can see the diffuse infiltrating. In diffuse infiltrating, you won't find a very discrete mass, but you see a thickened retina with a sometimes you see the with the anterior serines. So international classification for intra-ocular retinoblastoma is nothing new, but this is currently most accepted classification which is used. Group A is small, less than 3 millimeter in size, and then 1.5 mm away from the optic disc, and then 3 mm away from the fovea. Group B means big, and then there's subretinal fluid are very close. To less than 3 mm from the tumor lesion. You have got this group C retinoblastoma with the subretinal fluid or sitting very close to the tumor lesion of less than 3 millimeter of size. And D means diffuse, and this diffuse vitreous serines will be there, and that sometimes there will be total retinal detachment. And in group E, you see the tumor involve more than 50% of the globe, tumor almost touching the lens. You see the neovascular glaucoma, thysis bulbi, vitreous hemorrhage. You can see the tumor necrosis with aseptic cellulitis. So these consist of poor prognosis and then comes under group retinoblastoma. The new this classification, again, these 8 editions. The American Joint Committee for Cancer have this TNM classification. You have got this new one, this definition for heritable trait staging. The HX is the unknown or insufficient evidence of RB1 genes. X0 is normal RB1 alleles, and then H1 is bilateral or trilateral retinoblastoma with positive family history and molecular definition of constitutional RB1 gene mutation is there. The next is the International Retinoblastoma Staging System. This is important to prognosticate the survival. It's given by the Chandada et al. And then this divided into four stages. Stage 0 is treated conservatively. Stage 1 is enucleated, which has been tumor has been completely resected. Stage 2 with microscopic residuals. Stage 3 with regional extension, and stage 4 is metastasis. So coming to the treatment options available now, we have got chemotherapy, which can be intravenous, intraarterial, intravitreal, or periocular. And we have the focal therapy, this the transpeptide chemotherapy, laser photocoagulation, cryotherapy. And in radiation therapy, you have got plaque brachytherapy, external beam radiotherapy, or proton beam radiotherapy, and then enucleations. So basically, we are more focused now into this targeted chemotherapy. In 1990, the Japanese group have you know, started this intra-arterial chemotherapy, followed by another from Japanese group, Kaneko and Suzuki. In 2003, they started the intravitreal chemotherapy. And you have got the periocular therapy, which has been popularized by Dr. Santosh Hanavar. And you have got the intracranial chemotherapy by Muner et al. 2017. Intravenous chemotherapy, we have got standard chemotherapy, there's increasing etoposide carboplatin, the high dose chemotherapy is adjuvant, and the neoadjuvant chemotherapy. So the standard dose chemotherapy is usually given in group A to E, and the high dose chemotherapy is given when there is extraocular retinoblastoma is there, or optic nerve transection is there in case of high histopathologically, and we have got, if there is sclera, extrascleral extension is there, we use high dose chemotherapy. So intravenous chemotherapy use vincristine, etoposide, carboplatin, and then it basically reduces the volume of the intraocular tumors. So it's for example, it's a case of group D retinoblastoma. After 3 cycles, a very good response to chemotherapy out here with calcification of the tumor and completely regressed this retinal detachment out here. Another case with bilateral case, left eye is enucleated and right eye is group E retinoblastoma. After 6 high dose of chemotherapy regimen, you see a very good calcification and regress of the tumor. So another new thing is that the topotecan-based regimen for advanced intraocular retinoblastoma, where they show that 10 years survival is around 77.5% for group 5 and group 4 eyes, according to race as well classification. Next is intra-arterial chemotherapy. It's a primary option is for the unilateral group C, D, and E retinoblastoma, where you can use a single or double or triple drug regimen comprising of melphalan, topotecan, and carboplatin. Usually, it's give a high dose intraocular concentration of the drug without associated systemic adverse effect of the drugs. It's usually done by the intervention neuroradiologist. Using a fluoroscopic guided microcatheter has been passed from the femoral artery to carotid artery, and then it has been targeted to retinal tumors. So it has to be avoided, especially in case of advanced bilateral or extraocular retinoblastoma or RB1 germline mutations cases. This is the IAC protocol with age-based doses has been given here. So this is a case with a large group B retinoblastoma, macular retinoblastoma. So these are the ideal cases for the intra-arterial chemotherapy, where we have given here 2 cycles of ISC melphalan with topotecan. We see very good response to the chemotherapy out here. So another, it shows that primary therapy with globe salvage has got around for group B and group C is 100% globe salvage is there, and for group D is 94% and group E is 36%. So another case here. With group D RB, they have 4 cycle standard intravenous chemotherapy which is not responding. So another addition of 3 cycle of ISC comprised of melphalan and topotecan was given. So in a very good response and regression of tumor. Coming to the vitreous series is very difficult to treat and cumbersome because like vitreous is the series is vitreous is itself non-vascular tissue, and then the drug concentration is unable to reach there. So you have this classification out here: the dust type, the spherical type, and then the cloud type. So the treatment is usually two component, two drugs is melphalan and then topotecan. So this around 20 microgram is given, this topotecan injection, and then which have been, so topotecan has been a better bioavailability 5 times higher than the melphalan and has less retinal toxicity. So there's one case here with active vitreous series here. After 2 doses of intravitreal, you see a good response to the chemotherapy. Another is pericular chemotherapy. We give topotecan or carboplatin, which is used and adjuvant with IVC or ISC. And the advantage is that it gives a high dose. It achieves a high dose 6 to 10 times higher than achieved by the intravenous chemotherapy. The only disadvantage is goes orbital fat dystrophy or sometimes myelofibrosis and strabismus. And it has been shown in this Dr. Santos Handover's group that along with this perioperative topotecan with IVC, it will give it shows a high service rate of focal vitreous cysts around 95% with diffuse vitreous cysts 68%. So here's the case with so very good response to topotecan along with the IVC. Another is intracranial chemotherapy. We can use intracranial chemotherapy in along with this intra-arterial or intravitreal chemotherapy for taking care of this tumor seedings in the anterior chamber. Shown a very good response in this case report. Coming to the focal therapy, they have got laser photocoagulation, which is not used commonly now because out here in this use argon green laser around the tumor lesions, and then it restricts the blood supplies. And the reason behind not commonly used now is like not ideally when the patient is on active chemo reduction because it reduces the tumor concentration of chemotherapeutic agents. One example out here is group B retinoblastoma, 6 cycles of increasing interposite carboplatin, along with two sessions of laser photocoagulation out here, which is done from outside and it's referred to me here. And we have done the post-brachytherapy in this patient because in this case, IAC is not possible since these vessels are already regressed out here. The next is the transpulpal thermotherapy. It shows a semiconductor dyed laser uses pore size of 1,300 microns. And then this is pre-TTT and this is post-TTT showing a very good response in small tumor. Out here in this group B retinoblastoma, very near to the fovea. So out here we won't do the TTT, we could consider for intravenous chemotherapy. Another is transclear cryotherapy for tumor anterior to the equator. Small tumor, you see this lesion out here, this tumor. So after cryotherapy, you see the flat lesions. Next, coming to plug brachytherapy is another interesting modalities where it is used for residual and recurrent tumors where the conservative treatment models fail to regress. Usually thickness less than 6 mm and basal diameter less than 60 mm. However, it has to be avoided where there is active vitreous seedings and subretinal seedings, and then most common residual isotope used are ruthenium-106 and iodine 125, and then apex dose usually 4,000 to 4,500 centigrade. So here is one case with retinoblastoma recurrence of group C retinoblastoma. So after after this post brachytherapy, you see a very good regressed of the tumor. Another case here for the 4.5-year-old boy with group C retinoblastoma recurrent and recalcitrant to chemotherapy. You see a very good response after plaque brachytherapy. Another case with group B retinoblastoma. So next is external beam radiotherapy. Its indication mostly is extraocular orbital recurrence or positive optic nerve margins. The combination of EBRT and IVC has been shown with good response of achieved tumor control rate of 71%. The main disadvantage is because of orbital hyperplasia and the chances of secondary cancer. Enucleation, though it is all and methylating surgery, but still then its indication are very much currently in use. Indication is unilateral group E retinoblastoma, chemo reduction after extraocular retinoblastoma and recalcitrant with nil video prognosis. Various consideration has to be enucleation, and you give a very good prosthetic rehabilitations. Orbital retinoblastoma comprises of primary, secondary, accidental, overt, microscopic. You see that after neoadjuvant chemotherapy, this very good response to chemotherapy. And then you can do after chemotherapy, usually a 20 cycle of external radiotherapy, and then completed 12 cycle of chemotherapy. High dose chemotherapy have to be given in all this case. And management of metastatic retinoblastoma is very grim, and then the only encouraging result is with autologous stem cell rescue. which have shown 60 to 70, 80, 60 to 70% survival rate in this case. And this is one case of ours which shows a good response with chemotherapy. So this is the final slide. uh, the genetics is important out here. This is the father, and this is the two child which have got all this retinoblastoma bilateral. So germline mutation testing is very important, and when it is found to
With
positive,
all due to respect, I request
this is a
Dr.
life
Neiwete.
saving.
This is his last slide. 1 minute.
Yeah.
So there's a 50% of chances of passing down the cancer if there is a heritable disease is noted. So to conclude, retinoblastoma treatment is involve a multi-specialty contributions and highly individualized case-based approach with careful customized treatment regimen is required. And the current trends in managing retinoblastoma are targeted chemotherapy and focal therapy with the aim in giving a quality life eye quality life eye and vision service. Thank you all for your